Okay, it seems like the recording's started now, so maybe I'll get cracking because just turned the hour. So my name is Jack Lawson and I'm at the RVC, and I'm going to be presenting this very recent paper that is out at the moment on early view in the veterinary journal on urinary cystatin B as a marker of acute kidney injury in cats. So, by way of a bit of background, very briefly, as I know that cystatin B has been covered before in a recent journal club, but there is a need for biomarkers of kidney injury, as our traditional functional biomarkers have some important limitations. And creatinine is obviously the big biomarker that most people are using or historically have used to diagnose acute kidney injury. And the issue with creatinine is that the relationship between creatinine and GFR, firstly, is hyperbolic. So whereas creatinine is very good at detecting small changes in GFR when glomerular filtration rate is sharply reduced, it's of lesser utility when renal function is largely preserved. So as a result, glomerular filtration rate can reduce significantly before there's a clinically appreciable increase in creatinine. So ideally, we want to be detecting these patients with AKI earlier before there's this clinically appreciable increase. And secondly, the concentration of creatinine represents the degree of kidney dysfunction in acute kidney injury only when a steady state is reached. And I like this graph, which models serum creatinine concentrations after a severe AKI, which was defined in this paper as an abrupt 90% reduction in creatinine clearance. And this is superimposed on 4 different levels of baseline kidney function, no CKD through stage 2, 3, and 4. And this is from the medical literature, so they're talking about human staging. And then the solid squares on these lines show that points at which 100% increase in serum creatinine has occurred, and the open triangles are the point at which a 1 mg per deciliter increase has occurred. And as you can see, that steady state may not be achieved for days, and in the case of severe and sustained reduction in GFR, especially in patients with reduced kidney function to begin with. So again, we want something earlier than creatinine to help us pick up these patients. And these combined limitations mean that we've kind of historically found it difficult to diagnose and monitor kidney injury in the early phase. And furthermore, functional markers such as creatinine, as well as STMA and urea, don't detect kidney injury not associated with a decrease in GFR. And if you look at this diagram here, which I've stolen with permission from my colleague Hattie Syme, you can see how we might expect to use cystatin B, which is represented by BM, standing for biomarker here in this little diagram. And so if the kidneys are in their normal state in the top left, there's no damage or injury and there's no loss of function. So we would be hoping that the biomarker would be negative if we test for it, and serum creatinine would not change. But for instance, if there was a tubular injury that did not result in functional impairment, like the top right here, the biomarker would increase, even though serum creatinine doesn't move. And this patient here would be a patient that we otherwise wouldn't detect if we didn't have our biomarker. And again, hopefully this would be cystatin B that's going to kind of be useful in this scenario. And similarly, we can also use cystatin B to try and, or other biomarkers, to try and differentiate pre-renal azotemia from intrinsic AKI, as in a volume responsive AKI, like we can see here at the bottom left, where there's a loss of function, but no damage or injury, the creatinine will go up, but potentially the biomarker would be negative. Then in this bottom right, I guess we already kind of know these guys have kidney injury due to the serum creatinine increasing. And so maybe the biomarker being high is of little use. But maybe in this group, our biomarker such as cystatin B could be prognostic and add value that way. So I guess here is the kind of niche for something like cystatin B to come along. And why are we so focused on picking up AKI early? Well, late diagnosis of AKI might be associated with higher mortality rates, and early diagnosis might allow more timely therapeutic intervention when this therapeutic intervention is potentially most likely to succeed. and enter cystatin B into the equation, which is a relatively new test, which is offered by IDEX now. So the cystatins are a family of cysteine protease inhibitors, and cystatin B is an intracellular protein, meaning that if it's outside the cell, then some kind of cellular damage must have occurred, and the presence of cystatin B in the urine is therefore theorized to represent tubular injury and cellular damage that's occurred in the urinary tract, specifically the kidney. And the interpretation of the test at present, as given by IDEX, is split into this cutoff of under and over 100 nanogram per mil. So if it's under 100 nanogram per mil in the urine, this suggests a decreased potential for kidney injury. And if it's over or greater than or equal to 100 nanogram per mil, this suggests an increased risk of kidney injury. And what do we know so far about cystatin B and AKI? Well, there is some information out there already on its utility for the detection of AKI and prognostication of AKI in dogs. In this paper by Gordon and others, urinary cystatin B was compared between 10 healthy and 18 dogs with AKI. And you can see here on this scatter plot on the left, there's a clear difference between these groups, with the AKI group having much higher cystatin B concentrations than the healthy group. And the scatter plot on the right is showing urine cystatin B concentrations at baseline in dogs with AKI surviving 1 month, which is this group on the left, versus dogs that did not survive in the middle. And then we've got the controls again. And the non-survivors had significantly higher urinary cystatin B than the survivors. So as well as giving kind of diagnostic information, it was actually giving prognostic information as well. And in terms of early detection of AKI, which again seems to be an emphasis in where we might want to use this biomarker in clinical practice, we have this paper from Storebat and others from 2022 looking at urinary cystatin B in 19 dogs undergoing cardiopulmonary bypass surgery, which is a big risk factor for AKI in humans. And these time points represent the preoperative value at 1, and then 2 is the immediate postoperative value on the day of surgery. 3 is 2 days after surgery, and 4 is 4 days after surgery. And you can see that the cystatin B went up significantly after surgery if you look at the patients as a group, but that interestingly, serum creatinine did not across the whole group change. So maybe this is giving us some information regarding kidney injury that creatinine alone does not tell us. So onto the present study. So the hypothesis of this study was that urinary cystatin B will be present in the urine of cats sustaining AKI. And the aims of the authors were to evaluate urinary cystatin B as a diagnostic marker, firstly, and then secondly, to determine its utility as a prognostic indicator in cats with AKI. And this was done at the Koret School of Veterinary Medicine in Jerusalem. So there are 4 groups of cats utilized in this study. Firstly, they had a control group, which had an unremarkable clinical history, physical exam, urinalysis, serum creatinine, and SDMA. There was a urethral obstruction group, and urethral obstruction was based on history, clinical signs, and a firm unexpressible bladder. And these cats also had imaging to support this diagnosis and identify the underlying etiology of obstruction. Thirdly, there was a group of cats with CKD, and the CKD group contained cats diagnosed and staged as per the IRIS guidelines. And stage 1 cats were included based upon inadequate urine concentration after other disorders which could cause inadequate urine concentration were excluded, as well as ultrasound changes consistent with chronic kidney disease. And this group didn't include cats who had acute on chronic kidney disease. Those cats were included in the AKI group. And so finally, the AKI group, these were cats again diagnosed with AKI as per the IRIS guidelines. Grade 1 AKI was diagnosed where creatinine was within the normal range, and there was other evidence of AKI like cylinduria, glucosuria, or increased STMA, or indeed decreased urine production, or if there was an increase in creatinine by 0.3 mg per deciliter within a 48-hour interval within the non-azotemic range. And cats with AKI were classed as non-survivors if they died or were euthanized due to clinical deterioration despite therapy, which is important because cats that were euthanized before any attempts at medical management were excluded from the study. But yeah, they were classed as non-survivors if they died within 30 days from diagnosis, and cats were classed as survivors if they made it to 30 days. Cats in the AKI group were excluded from this group if there were any concurrent urinary tract diseases like neoplasia, UTI, or if azotemia was pre-renal. And in all groups, with the exception of the acute on chronic CKD group, cats diagnosed with more than one urinary tract condition, e.g. like UTI and CKD, were excluded, or if they had any other concurrent urinary tract diseases like neoplasia, or if there were systemic diseases thought that were present which were likely to affect kidney function. And these included things like neoplasia, endocrine conditions, immune-mediated conditions, or systemic infection. So all of these cats had a hematology, a biochemistry, a urinalysis, and a urine culture performed at their hospital's diagnostic laboratory. Urine was collected via cystocentesis mostly, but some of the urethral obstruction cats had urine collected by catheterization. And urine was processed and then stored at -80 degrees for up to 24 months, pending urinary cystatin B analysis. And urinary cystatin B was measured by IDEXX's research sandwich ELISA. And this ELISA uses monoclonal antibodies against the canine protein, but it was validated for use with these feline samples, and it seemed okay. It had dilutional linearity, spike and recovery was acceptable, intra-assay and inter-assay coefficients of variation were acceptable, and freeze-thaw stability was plus or minus 20% of the initial measurement. So seemed okay to use in cats. And in terms of data analysis, data were assessed for normality, and it must not have been normally distributed, cystatin B, because non-parametric tests were used. And the cystatin B was compared among groups using the Kruskal-Wallis test, followed by post-hoc pairwise Mann-Whitney-U test comparisons with the Bonn-Frohni's correction. Correlations between continuous variables were assessed via Spearman's rank tests, and then ROC curves were used to assess the predictive performance of urinary cystatin B for both the prediction of the presence of AKI and the prediction of outcome in the AKI cats. So there were two separate ROC curve analysis. And then optimal cutoff points for cystatin B for this prediction for the prediction of either AKI or survival were determined from those curves, and the optimal cutoff points were classed as those associated with the least misclassifications. So on to the results. So a total of 76 cats were included, and there was a roughly even split of male and female. And most of these cats were domestic short hairs, but there were also some fancier types in here too, in smaller numbers. So this population seemed to maybe just represent the general feline population at large. And breaking down the groups, there were 12 healthy controls, 9 cats with urethral obstruction, 17 cats with CKD, of which 2 of those had stage 1 CKD, 6 of them had stage 2, 8 had stage 3, and 1 had stage 4. And there were 38 cats with AKI, so this was the largest group, 2 of which had grade 1 AKI, and 3 of which had grade 2, 9 of which had grade 3, 13 of which had grade 4, and 10 of which had grade 5. So I guess you can see most it was biased towards cats with reasonable severity of AKI. There weren't many cats with a low grade of AKI. And in the AKI group, there were 15 cats which had no prior history of CKD, and 23 cats had acute on chronic CKD. And of those cats who had no prior history of CKD, etiologies included systemic inflammation, post-general anesthesia, and idiopathic in 4 cats each. 2 cats had cardiorenal syndrome, and 1 cat had Lilly intoxication. So kind of a bit of a heterogeneous mix of cats with in terms of causes of AKI in that group. I guess importantly, there were some baseline differences between these groups before they got to their analysis. Cats in the control group were significantly younger than all the other groups. So cats in the healthy control group had a median age of 15 months. So the healthy controls were really quite young. Cats in the CKD group were significantly older than cats in the AKI group and urethral obstruction group, and the median age of the CKD group were 156 months, so quite a bit older. But I mean, I guess you might clinically expect this given that they've got chronic kidney disease. And cats in the AKI group were older than the cats in the urethral obstruction group. So cats in the AKI group had a median age of 96 months, and the cats in the urethral obstruction group had a median age of 60 months. So there were some age differences which could be important. In terms of the creatinine, the median creatinine in the healthy controls was 0.85 mg per deciliter. In the urethral obstruction group, it was 2.4. In the CKD group, it was 3, and in the AKI group, it was 5.8. And the paper states that creatinine was significantly different among groups, although it doesn't go into it, that I can find anyway, as to which groups were different from which others, unless they were all different from one another, and it just doesn't quite spell that out. But certainly, there were some differences there. And regarding the cystatin B in healthy controls, the median was 22. And with a range of 11 to 154. So you can see, I guess, a couple of some healthy controls were over that 100 nanogram per mil cutoff that IDEX give you. And in the urethral obstruction group, median was 171. In the CKD group, median was 112. And in the AKI group, a lot higher, the median was 1052 nanogram per mil. And I guess interestingly, again, you can see at the lower end in some cats in the CKD and AKI group, some of these cats with what would be classed as significant kidney disease by other metrics have a relatively low urine cystatin B, which is interesting. Cool, but cystatin B differed significantly among groups. So compared to the controls, urine cystatin B was higher in both the AKI and the CKD groups, and the urine cystatin B of the AKI group was higher than both the CKD and the urethral obstruction groups. So seemed to be increased in cats with AKI compared to controls, and in cats with AKI compared to cats with other kinds of low urinary tract or other kinds of urinary tract disease like chronic kidney disease and urethral obstruction, which was nice. So in terms of the correlations, they weren't amazing, but urine cystatin B concentration was moderately correlated with serum creatinine and STMA. When looking at the whole cohort, so all of the cats together, if you just looked at the cats with AKI, there were no significant correlations between cystatin B and serum STMA or creatinine just within the AKI group. So it didn't seem to correlate in that subset, but in the whole population, there was this correlation. And then in the text of the results, the authors do pull out some interesting results that they found worthy of comment, which are interesting. So there were 2 cats with iris grade 1 AKI with very high urinary cystatin Bs, which you might not have expected given the creatinines in these grade 1 AKI patients. So perhaps again, these are cats where this biomarker is giving us some additional information as to the severity of their kidney injury versus creatinine alone. There were 2 cats with iris stage 1 CKD that had high urinary cystatin B, which I think is interesting in the context of the recent paper from dogs, which showed that dogs in iris stage 1 chronic kidney disease with higher urine cystatin B were more likely to be progressive. So perhaps these iris stage 1 cats with high urinary cystatin Bs were maybe worth following up on more closely than cats with a lower urinary cystatin B. And in the urethral obstruction group, 56% of cats had a urinary cystatin B concentration above the reference interval, perhaps suggesting that there had been some tubular damage as well as post-renal azotemia, that the azotemia just wasn't purely post-renal, there had been some intrinsic renal damage as well. So moving on to the ROC analysis. So in terms of looking at cystatin B for the prediction of AKI, if you just included healthy controls and the AKI cats in your ROC analysis, then the test was pretty good. The area under the curve was 0.92 out of 1. And then a cutoff of 84 nanogram per mil was quite sensitive and specific, so sensitivity of 90%, specificity of 92% for the diagnosis of AKI. But in some ways, this is a bit of an artificial grouping, I feel, because we're never going to be performing this test on perfectly healthy animals like these young control cats were to see whether they have an AKI or not. It's going to be hospitalized animals or animals presenting for some reason that is concerning their owners, that they've brought them to a veterinary practice. So there are likely to be patients that are unwell, essentially, that we're trying to differentiate between whether they've got an AKI or not. And maybe that was better reflected when the entire cohort was utilized with the urethral obstruction and CKD cats in it as well. And when you did that, the test was slightly worse, with a sensitivity of 76% and a specificity of 71% if you use this 180 nanogram per mil cutoff, which is obviously different to what IDEX is saying with 100 nanogram per mil at the moment for their algorithm on dogs. It would have been interesting to have some patients in here with extrarenal disease to see how this affects things as well. Does it affect the sensitivity and specificity if you have patients with other systemic comorbidities and things which could muddy the water. So moving on to look at mortality prediction, our kind of prognostic use of urinary cystatin B. So the 30-day mortality of the AKI group was 55%, which is reasonably representative of other reported mortality rates for AKI in cats in the literature. And interestingly, the median urinary cystatin B at admission was significantly higher in non-survivors at 1,572 compared with survivors, which was 584. And so, yes, there was a difference between these two groups, but could you use it to, how good was it at predicting in the ROC curve analysis? Well, it was reasonable. So as an outcome predictor, the area under the curve of their ROC analysis, which is here on the right, was 0.77. And a cutoff of 1,023 nanograms per mil was 71% sensitive and 71% specific. So it was kind of okay. But I guess the reportable range for urinary cystatin B is 50 to 500 nanograms per mil. So potentially this 1,000 nanogram per mil cutoff isn't that useful for anyone using the standard IDEX test rather than the research ELISA. So you're only going to know that it's over 500 rather than what the number is precisely. But they did another analysis where they excluded cats from acutes with acute on chronic CKD, which, if you remember, is about half the well, just under half, oh no, sorry, I think it was 23, so over half of the population of cats with AKI. But that exclusion improved the performance of this test. So it seems like the acute on chronic cats kind of confounded the analysis a bit. And without the acute on chronic guys, the area under the curve was 0.84, so it was a bit better. And a cutoff of 469 nanogram per mil was 100% sensitive and 75% specific for outcome. So in the discussion, the authors conclude that urinary cystatin B is a relatively sensitive marker of AKI in cats. But I guess don't forget that a few cats with AKI had urinary cystatin B in the reference interval, so it's not perfect. And then it depended on the reference population used. They quote 76 to 90% in their reference populations. But again, it would have maybe been nice to have some cats with other systemic disease in there to see how it performs in more of a real life veterinary scenario. Um, yeah, sorry. So urinary cystatin B may aid in the diagnosis of grade 1 AKI was another kind of comment that was made in their discussion. Um, so um, Two cats with iris grade 1 AKI had urinary cystatin B that was substantially above the cutoff. And so it could facilitate timely intervention aimed to support kidney function and minimize progression to higher AKI grades in this subset. But there are only a very small number of cats with low grade AKI in this study, which kind of limited assessment of that aspect. Interestingly, half of the cats in the urethral obstruction group had urinary cystatin B concentrations above the established reference interval. So, could this be indicative of tubular damage during the obstruction episode in this subset of cats? Seems reasonable to think that kidney damage could be triggered in these cats, as the authors describe, by increased intratubular pressure, local inflammation, and cytokine production. Yeah, maybe that is useful in determining which of these cats with urethral obstruction might go on to have more of a intrinsic kidney injury after the patency of the urethra has been regained. And finally, although this was primarily an AKI study, cats with CKD had increased cystatin B too. And that was interesting. And it was interesting that although these were all apparently stable cats with stable CKD, cystatin B was very variable in that population. So potentially cystatin B could contribute to better monitoring of these patients when we learn more about how this behaves in cats with chronic kidney disease, and whether it could be associated with a more severe phenotype or more progressive phenotype, although we don't have that information yet in cats. So there were some limitations of this study. The cohorts were of limited size, the biggest one being the AKI group, which was 38 cats, which was fairly decent size. Yeah, the groups weren't massive. The controls were younger, quite a bit younger. They were median age of 15 months, and the cats with CKD quite a bit older. And age could have had an effect, and age-matched groups maybe would have been an ideal, but the author's comment, it seems unlikely that age is going to have an impact on cystatin B concentration, but we just don't know yet, I guess. And the number of cats with iris grade 1 AKI were limited. So, the population that we're primarily interested in, I guess, in terms of picking up AKI sooner and intervening sooner and diagnosing AKI where we otherwise wouldn't have known about it, would be those kind of non-azotemic cats or cats with early renal injury, because almost the ship has sailed by the time their creatinine is going up, as I kind of spoke about earlier on in the talk. So it would have been nice to have a larger population of those cats. And again, although they looked at the freeze thaw of urinary cystatin B, the long-term stability of urinary cystatin B stored at -80 is undetermined. In this study, they stored it for up to 24 months. So we just don't know what effect that's going to have on the urine cystatin B. It says not to freeze on the IDEX website at the moment. I had a look, but I guess it would be good to know for all of our studies in future that are maybe going to use urinary cystatin B, how long we can keep these samples for without an effect. And urine was taken from cats with urethral obstruction at variable time points up to 24 hours after resolving obstruction. So this might have affected their urinary cystatin B concentrations. Maybe more of them will have had a high urinary cystatin B if we had a urine from at the point of deobstruction versus 24 hours later when maybe the injury has passed. We don't know. So again, that was another limitation. It also would have been nice potentially to have had a multivariable analysis to look at whether urinary cystatin B was an independent predictor of outcome alongside more established variables like creatinine, etc. But maybe the group sizes were too small for this kind of analysis, but it would have been interesting. I'd also be interested to know whether anyone had any knowledge of whether lower urinary tract inflammation could affect urinary cystatin B concentration, for instance, in those cats with urethral obstruction. I was looking around in the medical literature, and it seems that urinary cystatin B is increased in humans with bladder neoplasia, but I couldn't find much else about UTI, etc. But we know obviously that lower urinary tract inflammation can affect concentrations of other biomarkers like mGAL. So I'd be very interested to know afterwards if anyone has any data about whether lower urinary tract disease can affect urinary cystatin B. And I guess that brings me to my final point that we're only just starting to gain experience with this biomarker, so we probably don't know all the extrarenal influences on cystatin B, as well as we know those influences, for instance, on other biomarkers like creatinine, and this may affect our ability to interpret the results. So finally, I'd like to say thank you to the authors for bringing out such an interesting study, and thank you all for listening. And does anyone have any questions?
Thank you for that. That was a really nice summary. I just wanted to comment on the lower urinary tract infection. So we got involved with IDEX when they were trying to pick which biomarker to use. And we submitted a bunch of urines from dogs, not cats, from dogs with UTI. And it was not impacted in that population. But the population was kind of messy because it wasn't impacted by the ones that had clearly lower urinary tract, but there was a population of them that maybe had pyelo that were higher than you would expect. And so, you know, and we want to look further at it in pyelo to see if you can use it to help differentiate from upper from lower urinary tract. But it's a really good question. Very, very little data out there from dogs that I'm aware of that would address that. But the preliminary stuff we had suggested it. If it was clear lower urinary tract, it wasn't.
Thank you. That's really interesting. Yeah, I was definitely looking out for some information like that. Couldn't find any, but it's great to hear that someone has some experience of it. Okay. I guess if there's no one with any further questions, I'll let you all go. Thanks very much for joining me.
Thank you.
Thank you.
Bye.